Good morning, all. Rashid here. As all of you know, JSS College of Physiotherapy is organizing a webinar series from today on various topics as a part of World Physiotherapy Day. I welcome all of you for today's webinar. Today, we have Dr. John Ford with us. It is my pleasure to introduce Dr. John Ford, Associate Professor of Physiotherapy at La Trobe University and Clinical and Managing Director at Advanced Healthcare. Dr. Ford was one of the first physiotherapists to develop comprehensive treatment program in accordance with best available evidence and biopsychosocial approach and STOPS. STOPS is now being researched and studied across the world. We have been associated with him since 2017 in several projects, some of which are ongoing. It is our pleasure today to host him for this webinar. Over to you, Dr. Ford.
Thanks, Rashid, and thanks for the opportunity to present from Melbourne in Australia. So today I'm going to talk about individualized physiotherapy for low back pain. And hopefully my PowerPoint will work. There we go. So I'm going to talk just briefly about guideline-based care, then spend a reasonable amount of time talking about individualized assessment of low back pain. I'm aware that there's a range of practitioners and students with a range of experiences, but hopefully you'll find that section interesting because assessment is really the key to providing individualized physiotherapy. We'll then talk about some principles of individualizing physiotherapy based on assessment findings with some cases. And we'll compare three contemporary individualized physiotherapy approaches from a research and a clinical perspective. And finally, spend some time talking about the application of the STOPS approach, which is the individualized physiotherapy approach that we've developed and tested. In 2 hours, there's not a lot of opportunity to go into a lot of detail. I have put quite a lot of content into the presentation. So feel free to, if you've got any questions or if you're not following what I'm presenting, feel free to submit a question to the Q&A, and Rashid will put that up and I'll attempt to answer that live in real time. And we'll have some time for further Q&A at the end of the session, hopefully. Okay, so let's get going. Just talking about guideline-based care. So before, you'd all know that there's a low back pain epidemic across the world. The prevalence and disability has increased markedly over the last 25 years. And low back pain is really the number one cause or number one burden of disease through most countries, particularly Western countries. There's been over 2,000 randomised controlled trials if you look up PEDRO, and few of those trials can be synthesised to demonstrate significant and clinically important effects. And when effects are demonstrated, typically they're of a small effect size. So the effect size, the standardised mean difference is less than 0.5. So that's the nature of the problem. What are guidelines suggesting we should be doing in terms of treatment? There's been a number of syntheses, a number of papers and editions. So this Foster paper is from the Lancet series that most of you would probably be aware of. But in the last couple of years, there's been quite a lot of landmark papers synthesising all of the clinical guidelines around the world. And as you would be aware, clinical guidelines are intended to synthesise the research for practitioners in the field. So they're supposed to direct what we as practitioners should be doing as best available treatment. And what those clinical guidelines are recommending for acute low back pain is essentially advice and education as first-line care. And for chronic low back pain, advice, education, exercise, and cognitive behavioural therapy. And there's really no detail in terms of which exercises to provide, even which type of education to provide, because most exercise programs seem to be fairly equivalent. So does this first-line care that's recommended in guidelines work? Well, it's interesting if you go and have a look at it, because advice, which is essentially the first-line care for acute low back pain, there's actually no evidence to support the effectiveness of advice. pain education in acute low back pain is when you're talking about neurophysiological education to patients on the premise that minimising threat, minimising fear avoidance is going to prevent them developing chronic low back pain. But a recent RCT, high quality RCT by Traeger, showed that it was not more effective than placebo. So not a lot of evidence to support advice and education in acute low back pain. What about in chronic low back pain? So pain education in chronic low back pain, again, surprisingly, is not effective in isolation, but might have some short-term effect on disability if it's combined with other physiotherapy treatments. But again, the effect sizes are small and the duration of the effect is only short-term. And exercise and cognitive behavioural therapy, these are all systematic reviews. Again, surprisingly, even though they're recommended in clinical guidelines, really any effects of exercise and cognitive behavioural therapy are small in size. So limited evidence to support guideline-based care. And indeed, Foster, in the Lancet series, questioned the effectiveness and cost-effectiveness of these guideline-based treatments. So on the basis of the limited effectiveness of guideline-based care, some researchers, myself included, and our research team, have suggested that individualised treatment or physiotherapy might be the answer. And this concept, not surprisingly, is very prevalent in medicine. So if you look at a traditional approach to non-individualised care, so you have all of these people, different colours mean they've got different problems, and you treat them with the same medicine, so non-targeted treatment. And some of them, the blue ones, will get a positive response. Some of them will have no effect, and some of them, that treatment will actually have a counterproductive or unhelpful response. So a personalised or individualised approach to physiotherapy and medicine is you take all of these people, you do a diagnostic test, and you target the treatment based on that diagnostic test. So the blue people get the blue treatment, and the red people get the red treatment, and the purple people get the purple treatment, and everyone has a positive effect. So it sounds pretty straightforward and pretty simple, but unfortunately in back pain, if you look at the guidelines, that concept of individualised treatment really isn't what's being recommended. So if we're going to talk about trying to individualise our treatment and get larger effects, both in clinical practice and also in research, really the foundation of individualised care is, I'm just going to get my clock going. The foundation of individualised care is based on assessment. So if we're not doing a thorough and detailed assessment, particularly for our chronic low back pain patients, we're really going to struggle to provide high quality individualised treatment. So I'm going to spend a little bit of time going over the standard assessment processes that are taught in the undergraduate program in Australia. What I do find, though, and I'm an employer, I've employed probably hundreds of physiotherapists over the last 20 or 30 years, is that very few of those physiotherapists graduating from our undergraduate system actually have good assessment skills. So very few of them would actually do what I'm about to present on a routine basis. So I'm going to make this a little bit interactive. If you've got a pen and paper, maybe you can test yourself and see how you stand up against these criteria. So this is the standard assessment procedures for what I'm going to call today the subjective examination and the physical examination. And I'm going to go through these one by one. And if you've got a pen and paper or a computer screen, a Word document, whatever, maybe just test yourself with these. So from the patient's perspective, it's really important, I think, in contemporary physiotherapy to not have this hierarchical nature of the practitioner teaching the patient what they need to do, rather to be really working in a collaborative mutual partnership to help improve the patient's health and well-being. So from that perspective, understanding the patient's perspective is really important. So what sort of questions would you actually ask your patients with low back pain to understand their perspective? And you're probably not going to give you enough time to write them down. So maybe just think about them because we are a bit time limited. So these are some really useful questions. There's actually some data to support the relevance of these questions. What's the reason for the patient attending the clinic? What's the reason you're here today? Is a really nice opening question just to break the ice with the patient, build some rapport, and let them know that you're actually empathetic and caring and thinking about what their needs are. Understanding what the cause of pain is. What do you understand to be the cause of your pain is a question you can ask, which relates to the diagnosis. It could relate to other impairments as well. But obviously patients can sometimes have an unhelpful understanding of what the cause of their pain is, sometimes caused by other interactions they've had with health professionals. Recovery expectations is a really important factor with people with back pain. If you've got low recovery expectations, then it's likely that you're not going to do very well. So asking simple questions on their beliefs around prognosis can be helpful. And similarly, if a patient has a treatment preference that's completely incongruent with what you think the right treatment is going to be, they're not going to be very motivated to engage in your treatment program. So it's really important to understand what are you expecting will help your pain problem. And these are obviously generic for all musculoskeletal pain, not just back pain. So getting some simple questions around the patient perspective can be useful. The next part of the subjective examination is the body chart. And this is an area where very, very frequently practitioners tend to miss important detail. So this is just a typical body chart. There's different ways in which you can do it, but very important to obviously map out the location of the symptoms. Really important just to go and touch the patient on the body part, so the hamstring, the calf, any symptoms here, anything in your foot. Really what we call clearing those areas. So making sure that there's no pins and needles, paresthesia or numbness in the feet, because that can obviously have implications with regards to the source of the symptoms. Trying to map out so the C is for constant, map out whether it's constant, intermittent, whether it's deep, the nature of the pain, and also some sort of numerical rating scale. And if it's a constant pain, I tend to like, what's the lowest level of pain you've got and the most severe level of pain you've got. A really important thing when you've got multiple areas of pain is to try and ask the relationship question. So is this quadriceps pain related to your back pain? So when your back pain gets worse, does your quadriceps pain come on, and vice versa? Because if that does happen, it obviously means that this quadriceps pain is more likely to be coming from the lumbar spine. Conversely, they may have a quadriceps tear or some sort of other dysfunction with their quadriceps that's completely unrelated to their back problem. So asking the question of the patient regarding the relationships is a really important thing to do. So you make a really nice body chart, and then a really good history, particularly for your chronic pain patients, is a really essential thing to do quite well. And so I work in a tertiary setting where I'm working with psychologists and pain physicians, and most of the patients that I've seen have had injuries from 2, 3, 4, 5 years, sometimes 10, 20 years. And getting a really comprehensive understanding of that history, of that story, is really important. It's important from a number of different reasons. One reason is just to let the patient tell their story. So something's happened to this slide, but the first point should be letting the patient tell their story. It's a really important thing that the practitioner has the time to hear that story. Again, it develops rapport. It shows the patient that you're empathetic, and again, supports that collaborative relationship building with the patient. But obviously, we also want to look at past history leading to current history. Different practitioners have a different approach. I tend to, because I see lots of chronic pain patients, say, when did you first ever experience any of these pains that you've just told me about in the body chart? And from that first point in time, so it might have been an episode that started 20 years ago and they had episodes every 2 or 3 years and the episodes got more frequent. And then they had one big episode, and it's been a constant problem since then. So mapping out that story of the episodic going to a constant low back pain problem is really important. And similar in terms of this relationship concept. So which pains came on when? So if you look at that body chart, when did the quadriceps pain come on? Did it come on at the same time as the lumbar pain? And if it did, it suggests that there's a temporal relationship, a time-based relationship between the quads pain and lumbar pain, and it suggests that the quads pain is more likely to be a lumbar problem. So understanding which pains came on at what time is really important. Look, I'm not going to go through all of these in full detail because we'll run out of time, but I see a lot of workers' compensation people. I'm not sure about the compensation system for workers in India or the transport accident system, but in Australia there's quite a sophisticated compensation system. So patients, when they're injured at work or when they're injured in a traffic accident, get paid compensation for being off work due to their injury and get their treatment paid for. And that can introduce a whole range of complex behavioural secondary gain type problems. So exploring the work history is really important for compensable patients. But look, generally for any patient who is off work or having their work affected because of their low back pain problem, it's really important to understand what impact that's having on work, because obviously the person's going to be really motivated to get back to work for their own livelihood. Very important to get a detailed exploration of before and after the injury, what sort of exercises they were doing, what their activity, recreation and hobbies were, and what their pain response to these things are currently. So exercise is obviously a therapeutic modality that hopefully we're going to be using. And often the patients that I see are doing quite a lot of exercises that seem to be actually aggravating their pain. So they come in and I'll say, so they might be doing squats and deadlifts and lunges. And I say, so how do you feel after doing those exercises? And they say, oh, I'm sore for sort of 2 to 4 hours after doing them. So in that sort of scenario, it's likely that those exercises are actually unhelpful. So mapping out what exercises they're doing and the pain response is important. Obviously, activities, recreation, hobbies, that's going to give you information about the patient's pre-injury activities, what their goals are likely to be, and is going to help shape your treatment goals. I spent a lot of time going through what previous treatment the patients had, the nature of the treatment, the frequency, and particularly the response to the treatment. So if they've done arching exercises, lying on the stomach, doing prone extension in lying, asking them the question, how do those exercises, what effect do those exercises or that treatment approach have, which is a McKenzie type of treatment approach. Because again, it gives you clues about what you're going to do from a treatment perspective. And important to get some information about the recovery trajectory. So over the last, month or week, couple of weeks or 3 months, if it's a chronic pain problem, is it getting better, same or worse? Because we're looking at trying to change that trajectory. So if they're getting better over the last 2 months and then you come in and start providing treatment and they continue to get better, well, is it your treatment that's doing that, or is that just the natural recovery trajectory? So important to get that information. I'm not going to go through this in any great detail, but this is just a typical history that I would retrieve from a patient with chronic pain. So you can see, the reasonable level of detail that I would get from a patient with regards to the history. And if we had time, we could go through how that impacts upon your clinical reasoning and how that impacts on your individualised treatment. Ag and easing factors, so aggravating factors and easing factors. I'll probably skip through this reasonably quickly, but by the way, if any of you are struggling or are unsure about any of the concepts that I'm presenting, Nicole Petty, P-E-T-T-Y, has written a fantastic text on general principles of assessment and treatment. She's a British physiotherapist, And that's the text that we use in the undergraduate program at La Trobe, and I'd highly recommend it. She goes through all this in a lot more detail than what I'm presenting, and it's a fantastic text to bring you up to speed with best practice. But aggravating and easing factors, these can relate to the source of the symptoms. So, for example, we did an expert panel study that showed that experts think that these aggravating factors, so your back pain gets worse with sitting, bending, cough, sneeze, and gets better with walking, standing, and lying in prone, that when you've got these features, it's more likely that your pain's coming from the intervertebral disc. And there's a whole range of other aggravating factors that give you clues as to what the source of symptoms might be. Again, it's really important when you're doing these aggravating factors to continue to think about the relationship between symptoms. So you can have aggravating factors that selectively stress or are hypothesized to selectively stress different structures. So climbing stairs, left stance phase is more likely to provoke sacroiliac joint pain. So if you think about the sacrum and the ilium and your single leg stance, you're putting a shear force onto the sacroiliac joint as you're going up and down stairs or getting in and out of a car. Crossing legs is sort of an aggravating factor for hip problems, because people with hip OA tend to have struggle with flexion and adduction. Aggravating factors are also asterisks, which are basically key subjective features that can be used for evaluating change. So you can use sitting, the pain limit. So this is P2 is sitting's limited to 10 minutes by their low back pain. That's just a simple, very easily measurable asterisk for evaluating change between sessions. So if 2 weeks down the track they come in and they can sit for an hour, and it was 10 minutes initially, you know that they're getting better. And as I said, this relationship between symptoms. So when you do these aggravating factors, check whether it aggravates their lumbar pain, but also what effects happen on their leg pain. A few typos in there. 24-hour behaviour. So sleep, particularly in chronic pain, is really important. There's a lot of different mechanisms which impact upon sleep, which we're going to touch on a little bit later. So we take quite a detailed account of the patient's sleep pattern. In an acute situation, sleep dysfunction is probably more likely to be representative of inflammatory patterns, and is a really nice asterisk. When their sleep's improving, it's likely that the patient's actually getting better. So I would ask these sorts of questions around sleep. I'd also ask what sort of a mattress they've got, whether it's a saggy mattress or a firm mattress. All of these things give you information about whether it's more likely to be a mechanical problem that's going to be responsive to traditional physiotherapy, an inflammatory problem that might need some anti-inflammatory modalities, or indeed some sort of a neurophysiological based problem, which we'll touch on later. Morning symptoms: if they've got stiffness and pain that lasts greater than 60 minutes in the morning, that's generally thought of as being a feature of inflammation, along with night pain, significant night pain, as well as constant symptoms. And if in acute low back pain, I think identifying inflammation is something that's often missed. And when I used to see a more acute low back pain, than I basically don't see any acute low back pain anymore. But I used to very commonly send them away for a day or so with some anti-inflammatory modalities, some medication, gentle walking, taping, and avoiding provocative activities, and get them to come back a day or two later, and they'd come back and they'd be heaps better, and then I'd be able to do my more mechanically based treatments. So if you can identify those inflammatory patterns, that can be helpful. Naps during the day is a bit of an issue with sleep hygiene, what we call sleep hygiene, again, probably more with the chronic pain population. And how they're responding by the end of the day is also useful to know whether, excuse me, whether things that they're doing the day are potentially provoking their problem. So a really nice question to ask is, how's your back pain on your work days compared to your non-work days? And if they're feeling a lot better on the weekend when they're not working, then it's likely that work is a contributing factor. And if as a practitioner we don't identify that and address that, it's likely that regardless of what treatment we do, their back pain's not going to get better. So quite a lot from a 24-hour perspective. Special questions, I won't go through these. These are fairly standard. Just obviously need to be aware of red flags, comorbidities, general health issues. The more of these comorbidities and general health problems that our patients have got, the more likely they're going to become a chronic low back pain problem. And questionnaires, I might just sort of let you reflect on this just for a minute. What sort of questionnaires do you give your patients with back pain? So it's interesting, even in the so-called yellow flags concept, the idea of identifying psychosocial contributors to the back pain problem has become, very prominent. It's very much recommended in guidelines if you think about diagnosis. But when I do courses in Australia, still only a fraction of practitioners would actually use a risk screening tool. So these first two, the Arebro and the Start Back questionnaires, are both simple risk screening tools. They're easy to find online. We use the short form Arebro these days, which is 10 questions, and the Start Back is 7 questions. So very easy to use, but give you some nice information about what is the likelihood of them developing chronic low back pain due to psychosocial factors, and enable you to then drill into specific questions in more detail. So if they put an 8 out of 10 on the Arebro for depression, you can then say, oh, I noticed you've scored an 8 out of 10 for depression here. Would you mind explaining that to me a little bit more? Or is that related to your back problem, or is that something that's been pre-existing? So these sorts of questions help to elucidate from the patient additional psychosocial factors that may be relevant. Really important, again, particularly for chronic low back pain, to have some sort of functional outcome measure. So we're not just talking about recovery in terms of pain, we're talking about it in terms of function as well. So you can use the Oswestry or the Roland Morris for that. And then if you want to drill down into more detail from a psychosocial perspective, you can look at some of these questionnaires that are all available online, and again provide quite rich detail about these psychosocial barriers to recovery, which you can then specifically target with your individualized treatment. And we standardly give every patient that comes into our pain clinic these 4 questionnaires. You'd be familiar with the yellow flags concept, or the black, blue, red, orange, yellow flags. So this is just another way of thinking about risk for somebody with back pain. And again, I'm not going to go through this in detail, but I've just put it into the presentation for your information. Here's some of these beliefs, these yellow flags, emotional responses, pain behaviours, and you can see examples of that. So if people are coming up, really high on some of these yellow flags or orange flags or blue occupational or system-based flags, the black flags, and again, you're not treating those things, identifying and treating those things, it's really unlikely your patient is going to get better. So again, assessment is the key to individualized treatment. Okay, so that's the subjective. I'm just keeping an eye on the Q&A. If you do have any questions, feel free to put them into the Q&A. But I'm just going to go through this one by one. Observation is obviously very important, just informally to observe the body language, how the patient's sitting in the waiting room, how they walk into the clinic, what happens when they undress, how does that compare to when you're actually formally testing their movements, what's their posture like, what's their muscle bulk, muscle tone, muscle activation like, gait and functional movements. So again, standard sort of undergraduate observation skills. I've just put this in here. This is from some of Paul Hodges' work, who we're collaborating with on some motor control trials. Just have a look at these different sitting postures, and it's the same for standing posture. These postures exist in standing as well, and see what you can observe and what you might do if you actually saw this in the clinic. So a modern, we'll talk about this a little bit more later in the presentation, but a contemporary understanding of so-called motor control is more than just about muscle activation. It's also about evaluating posture and also evaluating movement patterns as well as muscle activation patterns, because they're all interrelated. So if you saw somebody sitting with this sort of a posture where they've got a very flat lumbar spine, compared to this sort of posture where they've got quite a long lordosis, and this sort of posture where they're obviously flexed, compared to this posture, which is the so-called optimal posture. Obviously, there's normal variations in posture, but the so-called optimal posture is when you've got a bit of a localized lower lumbar lordosis down here, as opposed to this long, Gwen Joel calls it a C lordosis, extending through the thoracolumbar junction. So how do you know whether these postures are helpful or unhelpful from a motor control perspective? And the simple way of doing it is a mini treatment where you assess the patient's resting pain, you identify these postures, and you correct them. So you try and get, in this situation, a little bit of localized lower lumbar lordosis. In this situation, you try and move the lordosis a little bit lower and flatten them out through the thoracolumbar junction. So they'd sort of probably pull their chest in a little bit and try and anteriorly pelvic tilt a little bit. A bit hard to demonstrate on Zoom. And obviously you're sort of trying to improve that lordosis as well. And then once you've corrected that posture, what effect does that have on pain? And if it improves their pain, then this posture is likely to be an unhelpful posture. It may actually make their pain worse, in which case the posture is actually a helpful posture. And so we're not going to be looking at treatment to correct it. What about this one? Have a look and see. This is from a cosmetic surgeon, I think, doing liposuction. But have a look at what you can see here from a posture and also from a muscle activation perspective. So very common sort of presentation. Quite often you can see there's just a beginning of an indent happening here at the umbilicus, which tends to mean that they've got an overactive rectus abdominis, but that's not particularly pronounced at this stage. You can see definitely some overactivity of the obliques through here with his indentation. Probably an underactivity of transversus abdominis and possibly internal obliques with this slightly, it's not particularly pronounced, but slightly protruding lower abdomen. So you can see a lot here about muscle activation and motor control. When you go to the back here, this is an example of, it's not a really high sort of C curve or long lumbar lordosis, but it is more in the upper lumbar spine as opposed to in the lower lumbar spine down here. So, and you can see that the erector spinae look like they're overactive. So with a good, nice lower lumbar lordosis, what you're going to see is increased activation of lumbar multifidus, whereas with this long C lordosis up through the thoracolumbar junction, it's more the erector spinae that are going to be working. So again, it's a combination of posture and muscle activation. So just through observation, you can really get a lot of information. Okay, so I've just got a question here about explaining this again. I'm not sure. This is a complex slide. I'll just very quickly go through it again. Basically, what is normal posture in standing and sitting is to have a lower lumbar lordosis. So you can see here, if you look at my arrow, that there's a lumbar lordosis focused on sort of the L3, 4, L5 sort of area. What you can see here is the lordosis they're pretty flat through this area, and the lordosis is actually happening through the whole thoracolumbar spine. So it's a long lordosis. And so if you then go and have a look at this patient, this is sort of a little bit of a combination of both of them, but it's a longer sort of lordosis with you can see the erector spinae here appear to be quite prominent and overactive, as opposed to having this lower lumbar lordosis, which is more optimal and means that the lumbar multifidus, if you think about the anatomy of the lumbar multifidus, it's focused in that lower lumbar area. That's where you palpate it, and that's where you get this lower lumbar lordosis from. There's also a whole lot of stuff going here at the front as well in terms of overactive external obliques, little bit of overactive rectus abdominis, but it's really the obliques with this indentation you can see here is overactive, and probably transversus abdominis. So you can see down here a protruding lower abdomen. So that's indicating that transversus abdominis is a little bit less active. So hopefully that explains it. Someone just asked for that. So just in terms of so a couple other questions that have come through. Mechanical back pain versus non-mechanical back pain. I will be going through that in a second. All of this information is highly relevant in determining whether it's more mechanical or psychosocial and neurophysiological barriers. There's another question here around any special thing in assessment for geriatric problems. Look, I think all of the things that I'm going through here are just as relevant in the geriatric population as for the younger populations. Obviously, your red flags are something to be more vigilant of in older populations in terms of cancer and vascular issues, intermittent claudication. If you're looking at what's happening radiologically with older populations, you're more likely to be getting intermittent claudication, foraminal and canal stenosis, those sorts of things. So there's certain types of low back pain that are probably more prevalent in the older populations. But the principles that we're applying here are equally applicable in older populations as well as younger populations. So keep the questions coming through. I will keep going. So that's just observation. So you can see how just with observation, there's quite a lot in there that you can look at. Active movement testing, pretty straightforward. We all do our standard movements. We can try and do quadrant. We can do combined movements. We're looking for quality of movement, the range of motion, the pain behaviour, and the end feel. And again, with active movement, we can get quite a lot of information about their posture, about their movement patterns, and what's happening with their muscle activation. So I want you just to reflect a little bit. Again, active movement is sort of something that's seen to be fairly standard. But what would your handling be to do extension over pressure or lumbar quadrant? Have a think about how you'd handle them. Would you have your hands on the shoulders and be pulling them back into lumbar extension, or some other type of handling? So look, these are not patient handling, as we know, is quite different depending upon the size of the practitioner, the size of the patient, the nature of the pain problem. But this is probably a better way of handling for lumbar extension. You can see here that you're able to isolate the sacrum from moving and really make sure that you're getting lumbar spine movement. The patient's head, if they're very hypermobile into extension, can drop back onto the practitioner's head to provide that extra support. And the patient feels very well supported. Extension, particularly if they're hypermobile, can be quite an unstable type of movement. So this would be my sort of go-to handling for lumbar extension over pressure. Similarly, for lateral flexion, you can get in nice and close, the patient's supported, and you can isolate it to the lumbar spine, or you can even bring your hand up higher and selectively overpress different parts of the upper, middle, or lower lumbar spine. The other good thing about these methods of handling is that you can actually get an eyeball and visualize what's happening segmentally. So you can see here with this patient, she's got a reasonably smooth curve going into left lateral flexion. She looks a little bit restricted in the lower lumbar spine down here. It's probably not as smooth down here as what we would like. And that's useful information. It might mean that there's some articular dysfunction happening on the left here. And this would be the handling for lumbar quadrant. Again, quite a provocative test. but a really nice, stable way of doing that technique. So just some ideas for you around handling. Okay, so we're talking about active movement and what you might be able to, additional information you might be able to get. One other thing about these handling methods is you get a really nice end feel. So what is restricting the movement? Is it soft tissue? Is it muscle guarding? Is it more a capsular ligamentous type of end feel? With this sort of handling, you're going to get really good end feels. Whereas if you've got the hands on the shoulders, the end feel is not as good. Okay, so I'm going to play this video for you, and I want you to see what movement patterns you can see, particularly where the movement is actually occurring. Let's have a look again. Where's the movement? Let's have a look at this one. Oh, that's the same one, I think. Sorry. All right, let's have a look at this one. See if you can see any difference. Okay, so this is actually quite tricky and goes to, I guess, particularly for students. I remember when I was a student, I found it very difficult and challenging with my observation skills to see some of these movement patterns that were actually happening. So it does take practice. You can see that this patient's actually got some movement, some motion sensors, one at the thoracolumbar junction and one on the sacrum. And one way of working out what's actually happening to the movement is actually having a look at these motion sensors and seeing which ones are moving. So hopefully some of you picked up that in this first picture, all of the movement was happening through the lumbar spine and virtually no movement was happening through anterior pelvic tilt. And she experienced 5 out of 10 pain with that. And we know from our normal kinematic analysis of the lumbar spine is that the movement should be shared between anterior pelvic tilt and also through the thoracolumbar spine. And so when you went to the second video after the patient had some retraining at increasing their anterior pelvic tilt, she actually moved further into lumbar flexion and her pain response was also quite a lot less. So this is an example of the movement component to motor control training. So remember, we're talking about motor control as posture and also muscle activation. So I'll just play them once more. Have a look at this lower sensor and see how much movement's happening at that lower sensor. It's really not moving that much, whereas the upper sensor is moving a lot. And this is the second one. You can see how far that lower sensor is moving in the second one. So by normalizing that anterior pelvic tilt as part of lumbar flexion, the active movement test, her pain response was improved. So that lack of anterior pelvic tilt was an unhelpful movement strategy for her. So again, active movement's often thought of as something sort of fairly simple, but actually can provide quite a lot of information. Now, there's been a question that's come through just around the fear avoidance beliefs questionnaire. Yeah, look, the fear avoidance beliefs questionnaire is a really useful questionnaire. I guess perhaps one limitation is that the whole questionnaire is dedicated to fear avoidance. 2 of the items on the short form Arebro are fear avoidance items. So for a screening questionnaire, I tend to use the Arebro and look at those 2 fear avoidance related items. And then when you're looking at the catastrophizing and self-efficacy questionnaires, they've got fear avoidance items on them as well. So I personally don't use the fear avoidance beliefs questionnaire or the Tampa questionnaire, which is another kinesiophobia, same thing, questionnaire for those reasons. So thanks for that question. Okay, let's keep going. I'm going to go through neurological examination and provocative neurodynamic testing, I'm just going to touch on them. Obviously, we need to do these particularly with people who've got peripheral symptoms. Yeah, think about your handling with these neurodynamic tests. You can see here, so for our patient, remember the body chart where they've got some quadriceps pain, some anterior thigh pain. You might want to do a femoral nerve slump test. You could do prone knee flexion, which is not a particularly specific test. But femoral nerve slump, this is a picture of femoral nerve slump, which again you can look up in the Cole Petty's book. So we've got them in a slump position through the thoraco lumbar spine and the cervical spine, and then we're bringing them into hip extension and knee flexion. And then if that reproduces their symptoms, we get them to extend the cervical spine to see whether that has an impact on their anterior thigh symptoms. And if it does, that indicates that there's a neural mechanosensitivity. So yeah, make sure you do those tests in the appropriate patients. Palpation, soft tissue, bony landmark palpation, PAVMs, physiological accessory intervertebral movements, and PIVMs, passive accessory intervertebral movements and passive physiological intervertebral movements, PIVMs. So these are your PAVMs, your accessory intervertebral movements. Again, you know, in the postgrad course, postgrad masters that I did sort of 15 years ago, we spent a lot of time practicing these skills. So just like all aspects of your assessment, really practicing these skills, getting your handling right, feeling R1, going through feeling to R2, and developing your capacity to sense that hypo or hypermobility, and obviously documenting what the patient's pain response to that is as well. Even bony landmarks and identifying where L4 is, where transverse processes are. You can see here on the transverse process it looks like L4 or maybe L5. You know, they can be challenging things, particularly for students to identify. So practice those skills or do a postgraduate course. All right, so this is the motor control thing. I'm just going to spend a little bit of time. This is Paul Hodges. So there was a series in Journal of Orthopaedic and Sports Physical Therapy in 2019 on motor control. If you're interested in motor control, I'd highly recommend you get access to that whole edition from that journal. And in that, Paul expresses this more contemporary sort of understanding of motor control. So not just about transversus abdominis activation, not just about multifidus activation, but about posture, movement, and muscle activation, identifying these suboptimal or unhelpful motor control faults, correcting them, which I gave some examples of that, and then optimizing that in a static or a dynamic situation, and then moving to optimal motor control in function. And understanding that all of these factors in green can have an impact on motor control and the low back pain. So we need to think about all of these things. So, you know, proprioceptive changes in the elderly population, balance changes, that's going to be potentially more relevant in the geriatric population. Strength, endurance, fitness, again, potentially more relevant in the geriatric population. Those sorts of things. So motor control is more than just about muscle activation. So I've got another video here. Just have a think about this person's motor control and what you might need to do to optimize it. So hopefully that's pretty obvious. Let's have a look at this fellow. So the point of all of this, again, remember we're talking about individualized treatment of back pain. The first person was obviously floppy. So if you wanted to sort of define her in one word, very underactive, in her muscles around her pelvis, around her lumbar spine, obviously had the Trendelenburg happening with the dropping of the contralateral pelvis on stance phase. So, getting increased muscle activation is going to be really important with that patient. Conversely, this fellow has got overactivity of all of his muscles. So you can see here his erector spinae are really very prominent. There's no movement at all happening through his lumbopelvic region. So he probably needs more movement and less muscle activation, whereas the first person needs less movement and more muscle activation. So just a pretty superficial but obvious example of motor control. So what about these two? This is sort of partly related to what we were talking about before. This comes from Peter O'Sullivan's paper. So Peter and Shirley Salmon are the people that really pioneered this idea of movement and how we can identify unhelpful movement patterns and optimize them. So what's happening in these two patients? So this one's similar to the lady that we were talking about in the video. So hardly any anterior pelvic tilt, lots of flexion happening through the lumbar spine, and this one's the exact opposite. It's all happening through the hips and it's not happening through the lumbar spine. And so identifying these movement patterns are really important. And again, we would assess them. We'd say, what's your pain response? We would correct those movement patterns and see if the pain response changed. Individualized treatment. So that's the movement side of things. Obviously, we still do want to think about muscle activation. So I'm not sure what it's like in India, but certainly in Australia, there's been a big push by some people against thinking about activating transversus abdominis and lumbar multifidus. And it's probably true that through the 90s, there was too great a focus on those muscles. But it's like everyone's sort of saying, well, no, we don't even think about that anymore. But, these muscles are important. The transversus abdominis does increase stiffness to the lumbar spine. So in that first female on the treadmill, getting some better activation of transversus abdominis might be helpful for it. And you can actually test that. Put her on the treadmill, see what her pain response is, get her down into, I prefer side lying rather than crook lying, get her down into side lying, and practice some TA, some transversus abdominis activation, get them back up again, put them on the treadmill, reassess what their pain is like. And it's actually amazing how just doing a little bit of correct activation of transversus abdominis can change these pain responses. And similarly with lumbar multifidus. So we do have some detailed treatment protocols around all of these things, which apart from Nicole Petty's text, I will direct you to at the end of the presentation. So if all of this is a bit sort of, you don't really know how to do this, that's fine. I'll give you some resources at the end of the presentation to help explain that. So yeah, let's identify helpful or unhelpful postures, movement, and muscle activation, optimize them through some training, and then optimize them through function. That's what a contemporary motor control approach is. And here are some examples of, so this is like a static. So you might retrain multifidus in side lying, then you might get them doing multifidus while doing this bird dog type exercise. And then you might progress them to doing multifidus in this. So that's a static exercise where the spine's maintaining a static posture. Then you might get them doing it in function, which is what a lunge is. So that's just an example of some of the different types of motor control exercises as you progress from optimizing it in non-weight bearing positions through to static or dynamic training through to function, which lunging is an example of that. Special tests, not going to spend too much time on this, except that, pelvic pain, the sacroiliac joint as a possible source of symptoms needs to be looked at in some patients. The McKenzie approach, which is implicit in the STOPS trials, which I'll talk about later on. And this concept of a mini treatment. So I've already touched on this. Do a little bit of treatment. You can use this with your PAVMs or your PIVMs. You can use it with your neurodynamic techniques. You can use it with your motor control techniques. Get an asterisk, apply a small amount of treatment, reassess and see if it creates a change. And if it does, you're thinking that that's the sort of treatment you're going to provide. Yeah, so just a quick slide on the McKenzie approach. In the STOPS trials, we didn't really worry so much about the postural dysfunction groups, focus more on the derangement group. And obviously, repeated extension in lying is sort of the go-to exercise for the McKenzie approach, which is also called mechanical diagnosis and therapy. Okay, so that was quite a long section on assessment, longer than what I suggested. So hopefully you found that helpful. Let's say you go through your assessment, you identify all of these findings. How's that actually going to impact upon your treatment? And look, this is something that our undergraduate students struggle with. This is a clinical reasoning model from Mark Jones. You can see down here, he's an internationally acknowledged expert on clinical reasoning. We call it the hypothesis framework. So you can generate hypotheses on the nature of the health problem. You can generate, which includes their pain type, the source of symptoms, pathology. You can generate hypotheses on whether certain clinical features might be relevant. So some impairments might be relevant, or they may not be relevant. So posture is an example of an impairment. As I said, you've got this so-called postural abnormality. Is that relevant to their back pain or not? So that's a hypothesis. Psychosocial factors, fear avoidance, whatever. And then some hypotheses regarding to the management of the health condition. So prognosis is one of those. You might have a hypothesis based on your high Arebro score, 75 out